Hey guys, welcome back to my channel, The ENT Resident. Today I'll be discussing a topic that a lot of you have requested to me in the last couple of months, and that is tympanoplasty. Now, this is not only important from the practical perspective of an ENT surgeon, where this is the one of the surgeries that is the bread and butter of an ENT surgeon. Other than that, it's also important in your examinations, not only in your theories but also in your viva, in your long case when you get a COM case and it leads to questioning in along the lines of tympanoplasty. So that's a topic for discussion today. It is a big topic, so I'll be breaking it up into two parts. So in today's part, I will be talking about a few definitions, a little bit about the physiology of middle ear and what exactly gets affected when there is a tympanic membrane perforation. We'll talk about the types of tympanoplasty, the different graft materials used, which graft is better, indications and contraindications of tympanoplasty, what are the prerequisites to tympanoplasty, and some what are the goals that we are trying to attain in it. And last of all, we'll discuss a little bit about preoperative evaluation of patients for tympanoplasty. So let's get started. So let's start with a few definitions. Now, this is something that has been a question in everybody's mind, like even mine when I was an MBBS student, which is not knowing the difference between myrincoplasty and type 1 tympanoplasty. Very often it is confused, and many people say that myrincoplasty is actually type 1 tympanoplasty, but that is absolutely wrong. So let's clear the confusion first. What is myrincoplasty? Myrincoplasty is an operation to repair the tympanic membrane perforation without inspection of the ossicular chain. This is very important to remember, without inspection of the ossicular chain. This is often wrongly referred to as type 1 tympanoplasty. Now, if this is myrincoplasty, what is tympanoplasty? Now, tympanoplasty is an operation to eradicate disease in the middle ear and to reconstruct the hearing mechanism with or without tympanic membrane grafting. So, tympanoplasty can involve a tympanic membrane grafting, it may not involve it as well. However, it will definitely involve checking of the ossicular chain status and subsequent ossicular reconstruction if needed. So, this is what tympanoplasty is. So, the main difference between myrincoplasty and tympanoplasty here is in myrincoplasty, it is only limited to repair of the tympanic membrane perforation, where you do not have to assess the status of the ossicular chain. Whereas in tympanoplasty, here, first of all, the first part of tympanoplasty involves removal of disease in the middle ear, and secondly, reconstructing the hearing mechanism with or without tympanic membrane grafting. And here, for sure, you have to check the ossicular chain status and subsequent ossicular reconstruction if needed. Next, let's talk a little bit about the physiology of middle ear. This is so that we understand how does normal sound conduction work and what happens when there is a tympanic membrane perforation and what are we trying to heal by doing a tympanoplasty here. So let's look at a little bit behind that. So, this is something that all of you must know. When you go underwater, you cannot hear any sound made in the air. And that's because 99.9% of the sound energy gets reflected away from the surface of water because of the impedance that is offered by it. Now, this phenomena, this impedance, there is a similar impedance that is seen in the ear as well, where the air conducted sound has to travel through cochlear fluids. Now, nature has compensated for this loss of sound energy, the loss of sound energy that happens because the air conducted sound is being transferred, it is traveling through cochlear fluids. The loss is compensated by interposing the middle ear, which the purpose of which is to convert sounds of greater amplitude but lesser force to that of lesser amplitude but greater force. And this function of ear is called the impedance matching mechanism or transformer action. This is a very important function, and this is achieved through certain three different ways. All of them add up to it. Sorry, this is achieved through two different ways. The first one is the lever action of ossicles. Now, if you see in the picture over here, you can see that the first one over here that you see is the malleus, this is the incus, and this is the stapes. And you'll see over here that the handle of the malleus is 1.3 times longer than the long process of incus, and this provides a mechanical advantage of 1.3. And the second way this impedance matching mechanism is made is through the hydraulic action of the tympanic membrane. Now, if you see in the picture over here, you can see that the area of tympanic membrane, this is the area of the tympanic membrane, is much larger than the area of the stapes footlet, which is just this much. And this average ratio is 21 is to 1. Now, even in the whole of the area of the tympanic membrane, the effective vibratory area of the tympanic membrane is only 2/3. Therefore, this effective areal ratio is reduced to 14 is to 1. And this is the mechanical advantage which is provided by the tympanic membrane. Now, these two combined, the lever action of ossicles and the hydraulic action of tympanic membrane, the product of these two leads to a factor which is 18 is to 1. So the ratio comes up to be 18 is to 1. Now, according to other people like Weber and Lawrence, they have hypothesized that out of a total of 90 millimeter square of tympanic membrane, only 55 millimeter square of it is functional. And given the area of stapes footplate, which is 3.2 millimeter square, the calculations turn out to be somewhat different. And here the areal ratio comes out to be 17 is to 1, and hence the total transformer ratio, which is 17 into 1.3, 1.3 being the lever action of the ossicles, it leads to a number of 22 is to 1. Now, we know the presence of round window. What is the importance of round window in the middle ear? The round window in the normal ear actually acts as a relief opening at the opposite end of the cochlear duct from the stapes footplate to permit the maximum to and fro vibratory movements of the non-compressible cochlear fluid column in the rigid bony cochlea. Now, in a normal ear, this round window membrane, the movements that happens in it are largely passive in response to the stapes footplate movement. And that is because 22 times the number that we just arrived at, 22.1, 22 times pressure increase at the oval window far exceeds any competitive pressure which is exerted on the round window from the tympanic cavity side. And an intact tympanic membrane protects the round window from any other competitive sounds, partly by damping it and partly by a phase difference. Now, the passive effects, the passive movements of the round window membrane, this is disrupted when there is a tympanic membrane perforation. So, in the patients which come to you with tympanic membrane perforation, here the round window starts to play a more active and a troubling role in the mechanics of hearing. So, what happens here is in a perforated tympanic membrane, sound reaches both the round and oval window at the same time, and thus it results in cancelling of the resultant movement of the perilymph. So, this leads to a hearing loss. Now, in an ideal tympanoplasty, the purpose of the surgery would be to restore the sound protective effect of the round window by constructing a closed and air containing middle ear and rebuild the sound pressure transformation mechanism for the oval window by connecting the tympanic membrane with the stapes footplate via either an intact or a reconstructed ossicular chain. So basically, the purpose of tympanoplasty over here would be to restore the sound protection effect to the round window by by how exactly we are creating a closed and air conducting middle ear. And here we are maintaining a continuity by reconstructing the ossicular chain in case it is not present. So that's what happens. That's how a tympanic membrane perforation affects hearing. Now, let's talk a little bit about healing of tympanic membrane perforation. How does it heal before we move on to the types of tympanoplasty? Now, the epidermis is the first layer that closes the tympanic membrane perforation. The healing of the fibrous layer occurs secondarily, and the site of response in this layer is related to the vascular distribution in the tympanic membrane. This process begins within 48 hours and it gets completed within 9 days. The epithelial layer of the healed tympanic membrane has been seen to not contain any basal cells, which proves the fact that its origin from migration from the periphery and not by in situ proliferation. So, this is just a little bit about understanding the physiology of the middle ear and what happens when a tympanic membrane perforation occurs and how the tympanic membrane gets healed. Now, we'll move on to more important parts, which is types of tympanoplasty. Now, Woolston in 1956 he classified tympanoplasty into 5 types. Now, in each of these 5 types, we'll talk about what is the defect that is seen and where do we place the graft. So, in type 1 tympanoplasty, the defect that is seen is there is only a perforation of the tympanic membrane. So, here we just repair it with a graft which is placed either on the malleus or on the remnant tympanic membrane. You see in the image over here, the malleus is intact over here. So, this is the tympanic membrane graft which we place either on the malleus itself or on the remnant tympanic membrane. In type 2, the defect is that there is a tympanic membrane perforation along with erosion of the malleus. Now here, since the malleus has been eroded, the graft is placed either on the incus, this is the incus in the image you see, either it is placed on the incus or if there is any remnant of malleus, it is placed on the remnant of malleus. In type 3, the defect is that malleus and incus are both absent. So you see only stapes over here. So in this case, the graft is placed on the stapes suprastructure as you can see over here. And this type 3 tympanoplasty is also known as myringostapidiopexy or columella tympanoplasty. This is a very commonly asked viva question in your practicals. Next, we move on to type 4 defect. Now, in type 4 defect, we see that only the footplate of stapes is present. Now, if there is only footplate of stapes which is on the oval window, where do we put the graft? So that there is some phase differential between the oval and the round window. So the graft here is placed in between the oval and the round windows. You can see in the image over here, this is the oval window, this is the round window, and the graft is placed in between the both of them. And as a result of this, a narrow middle ear gets created, which is also known as cavum minor. And this narrow middle ear is created to have an air pocket around the round window. A mucosa lined space extends from the eustachian tube to the round window. So, here what happens is the sound waves in this case act directly on the foot plate while the round window has been shielded, like in a normal physiology. Next is type 5. Now, in type 5, we see that the stapes foot plate is fixed, but the round window is still functioning. So, here what we do is we create another window since the stapes foot plate has been fixed over here. So, we need another window over here. So, another window is created on the lateral semicircular canal, and that is what gets covered with a graft. And so, type 5 tympanoplasty is also known as fenestration operation. And you can see in the image over here, this is the lateral semicircular canal. We create a fenestration or a window in this, and that's where we place the graft. So this is all about the types of tympanoplasty. Now we are going to talk about what are the different grafts that we use in tympanoplasty. Now, as you all must be knowing, the most common graft that is used is known as temporalis fascia. But another question that comes up is why is this the most common graft? There must be certain reasons behind it that it gained more popularity over the other grafts. That's a question that you frequently face in your viva when you get a long case on CSOM. So, the 5 reasons over here is first of all, the basal metabolic rate of temporalis fascia graft is very low. Second, it can be harvested from the same incision site as the surgery. The thickness is very similar to that of tympanic membrane, and you can attain a large size of the graft very easily. and the site is hidden in hairline, so it is cosmetically better. So these are the 5 reasons why temporalis fascia graft is the most common graft used in tympanoplasty. Next is the perichondrium. Perichondrium is either taken from the tragus or the concha. However, the tragal perichondrium is preferred because of 2 reasons. One is because it is easily harvested from there, and second is its long term reliability. The third graft here is cartilage, which again is taken from either tragus or concha. The tragus one is the tragal cartilage is preferred because of a good thickness and curvature and a very low metabolic rate. And in these cases where you are harvesting a cartilage, keeping the perichondrium attached to the cartilage will help you in placement of the graft and stabilizing it. So you should remember that when you are harvesting the cartilage. And what are the some indications of cartilage graft? Cartilage grafts are usually used in larger perforations, maybe of more than 50%, adhesive otitis media, and in revision surgery for recurrent perforations. Some other grafts used are the areolar tissue from the area overlying the temporalis fascia. The advantages of this graft is there is very minimal bleeding during removal due to its location in an avascular plane. It is also very easy to handle during the graft placement, and in case of failure, you can always get the temporalis fascia to replace it. And some other options are vein, periosteum, subcutaneous tissue, fat harvested from the lobule or the postauricular region, fascia lata, and alloderm. Alloderm is this is actually a material which is processed from human allograft skin when rendered immunologically inert. So these are all the grafts of tympanoplasty. Now we move on to indications of tympanoplasty. When do we perform tympanoplasty? Now, a very obvious answer is obviously when you see a tympanic membrane perforation and an associated hearing loss from it. Now, this tympanic membrane perforation could be the result of a disease process like CSOM or acute suppurative otitis media, or it could be due to trauma induced, or it could be due to barotrauma. So there could be multiple reasons behind the tympanic membrane perforation. So that is the most commonest indication. Second is when there is a hearing loss due to ossicular discontinuity and fixation of the ossicular chain. Third, in case of retraction pockets or atelectasis of tympanic membrane. Fourth, it is a part of cholesteatoma surgery. And fifth, in case of tympanosclerosis. What is tympanosclerosis? Tympanosclerosis are these white chalky deposits that get formed on the tympanic membrane and it reduces its mobility. So these are about the indications of tympanoplasty. So next, obviously, we also need to know what are the contraindications of tympanoplasty. So there are some absolute contraindications and some relative contraindication. So let's start with the absolute contraindications. First is in very poor general health, usually in elderlies. If the condition of the patient, the general health of the patient is very poor, we usually try to avoid doing tympanoplasty in them. Second is malignant tumors of the external or middle ear. Third, in an uncontrolled cholesteatoma case. Fourth, in unusual infections like malignant otitis externa. Fifth, in complications of chronic otitis media like meningitis, brain abscess, or lateral sinus thrombosis. And sixth, it is contraindicated on the only or the significantly better hearing ear in order to avoid the risk of irreversible sensory neural hearing loss in the well performing ear. So, these are some absolute contraindications. Now, let's talk about some relative contraindications. If there is any acute exacerbation of the chronic otitis media, or if there is any chronic mucoid discharge associated with allergic rhinitis or chronic otitis externa, basically, in case of any active infection, we usually try to not do the surgery at that point, but rather wait for the infection to resolve so that we can get better results from the surgery. However, this is not an absolute contraindication. In severe cases, you can actually just go ahead with prophylactic antibiotics. Second is a non functioning eustachian tube. This can actually lead to the outcomes getting affected. Third, tympanoplasty in children can be delayed until the age of 8 or 10 when the incidence of otitis media decreases and you are more likely to get a satisfactory outcome. And lastly, it is relatively contraindicated in repeated surgical failures due to extensive middle ear fibrosis, non functioning eustachian tube, recurrent perforations. These cases are better left alone, and patients should be given the option of a hearing aid. And last but not the least, there's another factor that you should all know about, which is smoking. Smoking, it has been seen in research that it has been seen to be a significant negative prognostic factor, and it has been associated with a threefold increase in long term graft failure. So, this is all about the absolute and the relative contraindications of tympanoplasty. Next, let's talk about what are some principles that we have to remember when we are trying to restore the hearing of a patient who has come to you with the main complaint of hearing loss. So, there are 6 principles to remember here. The first one is, first of all, you need an intact tympanic membrane. This intact tympanic membrane will provide the large hydraulic ratio between the tympanic membrane and stapes footplate, as I was just discussing before. Second, ossicular chain. We need an intact ossicular chain to conduct the sound from the tympanic membrane to the oval window. Third, we need 2 functioning windows. One is on the scala vestibuli to receive the sound vibration, and another on the scala tympani to act as a relief window. So, this is the oval window and the round window. Fourth, we need an acoustic separation between these 2 windows so that the sound is not reaching both the windows simultaneously. If it does end up reaching both the windows simultaneously, there will be no phase differential at all, and as a result of which, the sound will not be conducted. Fifth, we need a functioning eustachian tube which can provide aeration to the middle ear. And lastly, we need a functioning sensory neural apparatus, which means a functioning or a normal cochlea and auditory nerve. So, these are the 6 principles you need to remember when you're trying to restore the hearing of a patient. Now, let's talk about what are the prerequisites of tympanic membrane repair. What are the prerequisites in a case of laryngoplasty or a tympanoplasty? These are some basic things that you have to remember. The first one is the ear should be dry at least 3 months before the surgery. Now, this is all I already mentioned. This is not an absolute contraindication, but it is preferable if you are able to get the ear dry for 3 months prior to surgery. You will definitely get better results and better outcomes from the surgery. Second, the eustachian tube should be patent. Third, there should be no focus of infection in the nose, paranasal sinus, and the nasopharynx. Fourth, the cochlear function should be good. And fifth, the mucosa of the middle ear should be healthy. So these are the 5 prerequisites to performing a tympanic membrane repair. Next, let's talk about the surgery here that we are performing, tympanoplasty. What are the goals that you're trying to achieve by performing this surgery? There are only 2 goals, and both of them are equally important. First goal is that you are trying to achieve a dry ear by eradicating middle ear disease. And secondly, after you have eradicated the disease, your goal is to restore the hearing or lead to some hearing improvement by closure of any tympanic membrane perforation by either grafting and or ossicular chain reconstruction. So these are your 2 goals. First, you make the ear dry and eradicate the middle ear disease. And secondly, you try to achieve hearing improvement by either grafting or ossicular chain reconstruction. So now that we have learned all the background behind this, now a patient has actually come to you who needs a tympanoplasty. So what is the evaluation that you'll carry out in such a patient? That is also very important to know. So let's talk about preoperative evaluation of a patient for whom you're going to perform tympanoplasty. First of all, you need a complete history and a complete head and neck examination. You should perform a otoscopic examination and tuning fork tests. You should definitely see the ear of the patient under microscope. So, examination under microscope is very, very important. You should definitely perform this preoperatively. Coming to this, do you know the focal length of the microscope that is used for ears? The focal length for microscope that is used in ear surgeries is 200 millimeter. And the focal length of the microscope used in nose surgeries is 300 millimeter, and in larynx is 400 millimeter. Anyway, next moving on. Then we have to perform an audiogram of the patient, which should be done within 3 months, prior to 3 months, not more than that. This should consist of a pure tone audiogram and a speech discrimination score. This will help you understand the loss of the patient, and this will also help in the patient understanding the improvement that they get from the surgery after the surgery has been performed. Now, these are the basics that you do. Other than this, do you think that imaging is important in tympanoplasty cases? And if yes, when is it needed? So, first of all, any regular cases like the dry chronic central perforations, you do not need to perform any preoperative imaging at all. Pre-operative imaging is only required in very few cases. Now, let's discuss those. So, a high resolution computed tomography of the temporal bone, this is done only for cases with cholesteatoma, atelectasis, and chronic drainage. And why do we do this? This helps in determining the disease extension, any possible intracranial involvement, the degree of mastoid pneumatization, and what is the type of surgical approach you need to use, presence of any labyrinthine fistula, and to look at the facial nerve canal anatomy as well as any tegmental or dural defects. So in very complicated cases like that of cholesteatoma, atelectasis, and chronic drainage of the ear, these are some things that you can notice by doing a high resolution computed tomography of the temporal bone. And when is MRI temporal bone done? This is only done uh, for diagnosis of brain herniation if you have seen on CT that there is a tegmental defect present. So, to check if there is any brain herniation or not, and that time we do a MRI of the temporal bone. So, this is about the imaging in case of a tympanoplasty patient. Now, say a patient has come to you with an actively draining ear and you're going to perform the surgery in this patient. In those cases, the external auditory canal should be suctioned and all of these the pus or mucus should be cleaned out, and the patient should be instructed to keep the ear dry. And for very refractory cases, the ear can be irrigated with a solution of 1.5% acetic acid 2 to 3 times a day. And even antibiotic drops coverage should be given, especially covering Pseudomonas aeruginosa. And you should also look into making all the effort you can to control any condition that can predispose to failure of the outcome of your surgery, like if there is an adenoid hypertrophy or recurrent tonsillitis in children, or allergic rhinitis, allergic sinusitis, or nasal obstruction secondary to deviated septum. So, in all of these cases, to improve the outcomes of tympanoplasty, first you should take care of these conditions. So now you have done all of the preoperative evaluation. Now you have to talk to your first. You should get informed consent from your patient. And while you're getting an informed consent from your patient, there should be certain things that should be explained to them, like what is the nature of the disease process over here? What are the treatment options that your patient has? And what is the surgical procedure that you are proposing over here? And what would be the expected outcomes? What are the potential risks and complications of this surgery? And if there is a possibility that a second stage procedure might be required. So, these are all things that you should explain to the patient prior to doing the surgery and get an informed consent from them. So that's all for today. And I'll continue in the next video about the second part of tympanoplasty, the more important part that you're all waiting for, which is the steps, the procedure, and the different techniques of surgery and what are the possible complications that come from it. So I'll see you in my next video. Thank you.